Good morning and welcome to the George Institute for this George Talk. My name is Vlado Perkovic. I'm the Executive Director of the George Institute here in Australia. Before we start today, I'd like to welcome Auntie Anne Weldon, who's going to do a welcome to country for us. Auntie Anne, please.
Good morning, everybody. Good morning, Katherine, the Honourable Catherine King, and of course, thank you for your introduction. And what a beautiful, beautiful building and a glorious day it is in this spectacular top of the King Street, Newtown. Who would have thought that in King Street, Newtown, you'd have a view like this overlooking the city? I need to make you aware, my name's Anne Weldon. I was actually born Anne Coe, and I'm a Wiradjuri Koori Balan. Wiradjuri, and I've said this through the hundreds of welcome to countries, that Wiradjuri is the mightiest of Aboriginal nations in this country yet to be disputed. Koori is Aboriginal. It's my word is our language for Aboriginal, and Balang is also our language for woman. And I grew up in Irambi Aboriginal Reserve in Cowra, New South Wales, and I belong to the Clare River people. And when I was born, we didn't exist in our country. We weren't even classified as human beings or citizens. And when my mother gave birth to myself and my sisters, like all of the children of our particular era, she had to give birth to me in the segregated section of Cowra District Hospital. And but we were certainly a lot better than, well, more fortunate than the ladies in Moree, because they had to have their children in a tent outside of the hospital. And when my grandfather and my dad and my uncles had to, like, for them to work, they had to be issued with what most Aboriginal people refer to as dog tags to make them honorary whites so they could actually leave that reserve to work. My dad was a fettler on the railway, and his dad was a drover along with his brother. So, but when I get to stand up at welcomes, and I've done quite a few in very incredible places and met some brilliant people, I often tell them of how my life began, and I feel honoured, you know, and I pinch myself at times to think, well, who would have thought this little old, you know, this little Aborigine girl, this Wiradjuri kid that roamed around that mission, because that's all we had was our mission, would be standing in such an incredible building here in Newtown on this fine sunny day. You know, it shows you where or how things can go and where you can end up, and no doubt with the brilliance that's in this room, you certainly will make life a lot easier for a lot of other people. Just to make you also aware, I'm an elder of New South Wales Aboriginal Land Council and a board member of Metropolitan Local Aboriginal Land Council, and their representative here this morning. The Metropolitan Local Aboriginal Land Council is the cultural authority and custodian of culture, heritage, land and waterways in this particular part of Sydney. And I stand proud of my people's richness of culture and our strong resilience. And I acknowledge other Aboriginal, Torres Strait Islanders and non-Aboriginal brothers and sisters here in this room this morning. I acknowledge the owners of the land on which we gather, the Eora Nation and the Gadigal clan, for the Gadigal clan were one of 29 clan groups of the Eora Nation. I pay my respects to all elders, past, present and indeed elders of tomorrow from our many Aboriginal nations across our lands, and express my deepest appreciation and realise our elders made many sacrifices, and it was through fortitude, courage and their wisdom to build a better future for us all. But undeniably, history has dealt my people unjust treatment, and sadly we witness and continue to be paralysed by these unfortunate injustices. For my people, Aboriginal Australia, we have existed and belong to these lands that stretches beyond 60,000 years. We are the richest and the oldest continuing culture in the world. And our practices of culture and language have been handed down to hundreds and hundreds of generations. And as I speak, I'm certainly ensuring that my grandchildren and grandnieces and nephews, it's being handed on to them as well. For I learnt my Wiradjuri culture and traditions by the teaching and by listening to my elders. For my elders informed the truth from their life experiences and the facts that they'd seen through their eyes. And we call them the strong, clever ones. And as a Wiradjuri Kuribalang, I would like you to celebrate and to be proud and stand with us, to walk beside us, not walk ahead of us, and allow us, Aboriginal people, to share the wealth in our country so that we can create our own pathways to reach our full potential. For Metropolitan Local Aboriginal Land Council, we certainly promote a vision of working together as one community and to achieve as one community. And our boundary spans from the Hawkesbury River to the north, the Nepean to the west and the Georges River to the south. So as an elder and a board member of Metropolitan Local Aboriginal Land Council, but with their permission, it is with honour I welcome everybody here this morning to the land of the Eora Nation. And I also take this opportunity to thank the George Institute for inviting me to conduct the Welcome at Your Better Health for All policy conversation, for your significant contribution, your dedication and commitment. And I know that you certainly would, within your profession, be looking at Aboriginal health. And it's because of dedicated people such as yourselves. And in fact, our Aboriginal community control organisations such as the Aboriginal Medical Service and Aboriginal Health and Medical Research Council, that I'm standing before you. I mean, I'm a walking dead woman as it is, I've certainly reached an age where life expectancy, I've gone beyond. As, many of my family members were only very young. And, I've lost brothers and sisters that were in their 30s that have died from, heart attacks. And the most tragic one was my sister from diabetes and renal failure, who just got beyond 50. So we live with death. But, it's because of people like yourselves that certainly are committed, to do the research that you have done that has enabled me to stand before you this morning, even though I've got to pop quite a few pills to get here, but at least, I am here and I get to stand before such incredible people that dedicate their lives to and are certainly committed to bring about positive health outcomes, not only with the broader community, but specifically with Aboriginal communities. So, thank you. There's one thing that I always ask when I get to do welcomes is for people, everybody. I ask all of you to remember the ones that have passed over before us, the ones that have allowed each and every one of us to stand on their shoulders, the beautiful people sitting beside you now, and those incredible little ones that follow in our footsteps. So may my people's spirit walk and guide all of us as we continue on that journey together, and let that journey be one where we can certainly continue to develop, or you can with us, develop meaningful and tremendous partnerships with Metropolitan Local Aboriginal Land Council, because I know under our present leadership we've certainly put our hand out to develop solid partnerships to allow all of us to collectively address issues that impact on our communities together. So once again, welcome to the land of the Eora Nation. Always was, always will be Aboriginal land. Thank you.
So thank you so much, Auntie Anne, for those words that remind us of some of the challenges that we've had in the past, some of the achievements as a country that we've made, but also just how far we've still got to go. And I'd like to also extend my respect to you, to elders past and present, to those wonderful emerging Aboriginal leaders we've got here in the room, and acknowledge the traditional owners of the land, the Gadigal people of the Eora Nation. I'd also very much like to welcome the Honourable Catherine King, the Shadow Minister for Health and Medicare, who's the person who's got us all out of bed nice and early. So if you're grumpy, we can blame me, don't blame Katherine. And welcome all the distinguished guests we've got here today, members of our board, representatives of a broad range of organisations that are interested in health. And we've just heard a powerful explanation of why that's important. It's, we have made a lot of progress, but we've got so far to go. Indeed, there's some data now coming out of the US that suggests that over the last 2 years, life expectancy here in Australia may have gone backwards for the first time since the Second World War, and for the first time this century in a non-wartime setting. So not only do we need to keep extending what we've already done, but there may be new challenges that we need to face going forward. We at the George Institute are very much committed to trying to address the health needs of people here in Australia, Aboriginal communities, the broader Australian population, the people in our region and the people around the world. And there is a lot to do. We very much focus on the most important conditions causing the greatest burden of illness and premature death, chronic disease and injury in particular. And we're established in 1999 to achieve that, with many operations now around the world. One of the things we're very much interested in doing is moving forward the conversation across the community about how we do this. And we need to constantly be asking ourselves, as a community, as people working in health and in research, are we doing the best that we can do to really maximise the health and optimise the health of people in Australia and around the world? Depending on what happens this coming weekend, we could be in an election period very, very soon. And depending on the outcome of that election, it's entirely possible that we might have a new health minister, and one of the people who may be in that role is our special guest here today, Catherine King. So I'm very much looking forward, Katherine, to hearing what you've got to tell us about your vision for how we might, as a nation, as a group, work together to improve health and what the priorities are. So on that note, I'd like to welcome you up to give your remarks. Thank you.
Thanks very much for that introduction. And I too would like to start by acknowledging the traditional custodians of the land on which we gather and pay my respects to elders past, present and future, and particularly to Auntie Anne. I know she's had to go, but her words very powerfully remind us that the segregation, isolation and disenfranchisement of Aboriginal and Torres Strait Islander people has happened in our generation. And so it is our generation's responsibility to actually walk alongside Koori people to actually achieve change. To Professor Vlado Perkovic, I don't know if many people know, but my husband has Croatian heritage as well. And I suspect that your household, and I suspect your workplace, has had the same experience recently because of the great achievements of Croatia at the World Cup. To hear what a fantastic sporting nation Croatia is. Who knew? Tennis, basketball, football. That's been the topic of my household, and I'm sure has been the same of yours. But thank you very much for having me here. And to all of the assembled guests here, many of whom I know or have met with over the course of my time as Shadow Minister for Health and previously. Look, it has only been 2 years or just over 2 years since the last federal election in which health policy was a key battleground. This weekend, voters in 5 electorates will go back to the polls in what media has dubbed the Super Saturday of by-elections. And again, health policy has been a big focus of those. Just ask the poor staff at Caboolture Hospital who've had to put up with the visiting politician, I think, every day for the last 2 months. I bet they're counting down the days until this is over, much like we are with 5 to go. But over the last 8 weeks, as I've been crisscrossing the country, meeting Labor's candidates and helping out in those campaigns, the message has been overwhelmingly clear. Voters in those 5 seats, just like those in the other 145 across the nation, care very, very deeply about our healthcare system and their access to healthcare. That's no surprise because health regularly ranks as the highest priority for voters in opinion polls. So when the next general election rolls around, probably sooner rather than later, health will be at the core of that campaign as well. Labor will make sure that it is, because it is one of our highest priorities as well. And we do have a very genuine philosophical difference with the Conservatives about how best to fund and how to deliver healthcare in this nation. All of which to say is it does often feel as though we are in permanent campaign mode in federal politics. Barely has the last election passed when we're preparing for the next one. And that, as I'm sure everyone in this room keenly appreciates, can lead to short-termism when policy making gets hijacked about what will win votes rather than what will be best for our long-term future. It's a problem of the nature of our political system and our political cycles. That's why it's always very refreshing to come to places like the George Institute, because you are an audience who does want to hear about Labor's long-term vision for healthcare in this country. And make no mistake, there are some big questions that we have been pondering. Questions like, what should our healthcare system look like in 10 to 20 years' time? How do we better promote health and prevent disease so that fewer people need healthcare to begin with? How do we reshape primary care in our hospital system to truly meet the challenges of our expanding and ageing population? And how do we achieve true universality, our WHO vision, so that all Australians can access timely, quality, affordable care when they need it, regardless of socioeconomic status or of their geographic location? These are the sorts of questions that people like myself do grapple with every day. And today I want to give you a bit of an insight into our thinking. First, I want to talk about prevention. It's the first thing I think about when I think about health policy. All of you know the extraordinary burden of chronic disease in our society, the cost to individuals, to families, to communities, and our society as a whole is enormous. Around 7 million Australians have a chronic condition. Nearly 90% of premature deaths have chronic disease as an underlying cause. The cost to the health system is many billions of dollars. And prevention, as we know, is the key to reducing much of that burden. And yet, apart from the calls for a sugar tax that are starting to get traction in the media and the public consciousness, prevention has completely fallen off the political agenda. Our spending on prevention remains a tiny proportion of our overall health budget. Other similar developed nations spend 5 times as much. I want prevention to be at the very forefront of our national conversation about health. In explaining why it's not and why Australia is languishing so far behind on this, I'm going to strike something of a political note that some of you might find a bit uncomfortable or a bit tiresome, but I'm sure have heard from me before. The last Labor government did take prevention very seriously. The fight over tobacco plain packaging was perhaps the most high profile and contentious of our preventative measures. But if you talk to Nicola Roxon, she'll tell you, in fact, it was probably one of the easiest. But it was certainly not all that we did. We established the National Prevention Health Task Force, which developed a 10-year roadmap for action on obesity, tobacco and alcohol, much of which remains relevant today. We established the Australian National Preventative Health Agency so that governments would receive ongoing expert advice on disease prevention. We did so because we wanted to make sure we had the long-term policy settings right. At the last federal election, we sought to extend this record with a new $300 million investment in prevention. Because talk is cheap, prevention needs investment. I was very proud of this package, but sadly, as you all know, we did not get the opportunity to implement it. The Liberals, meanwhile, have spent the last 5 years gutting health promotion and disease prevention programs. It abandoned the national partnership agreements on preventative health with the states and ripped up the remaining $368 million into prevention. It abolished the Australian National Preventative Health Agency, the best source of advice on keeping Australians healthy, for a measly savings of $1 million. Since then, we've heard barely a peep from them on prevention. They've been completely missing in action. And yet, they've suffered next to no political pain for it. Right now, prevention is a very hard sell politically. When the budget is tight, it's not easy for any politician to convince their colleagues that they should invest hundreds of millions of dollars in policies that will only pay long-term dividends and in more likelihood won't win any votes. To change that dynamic, we need a national conversation about prevention, and it can't just come from politicians. We need fierce advocates for prevention. We need strong, united stakeholders who are willing to hold the government to account when they cut prevention programs or when they're not taking it seriously enough. And we need thinkers and experts like you to help as well, to talk to the voting public, to explain why prevention is important and why government has a role, why it requires a significant investment of taxpayer dollars, and how that investment could improve and extend lives. Without that national conversation, we will be forever mired in the status quo, where we continue to pour billions of dollars into treating diseases rather than preventing them. Right now, the prevention agenda is stalled, and I'm committing to getting it going again, but I can't do that alone. I also want to talk to you about primary care and about hospitals. Primary care, of course, is the front line of our healthcare system. A strong primary care system, which includes a focus on prevention, health promotion and disease prevention, and early detection of those at high risk, is critical to addressing chronic disease. An older population with higher rates of chronic disease means Australians will need more care and different types of that care at different points in time. Labor's ultimate vision for primary care that is still led by GPs, but much more integrated with other specialists, allied health and other health providers. We also want much better coordination between primary care and hospitals. That isn't easy, and we're not so arrogant to assume that there is a one-size-fits-all model that will work, but it's simply something that has to be done. And in this space, innovation is important, but so is investment. The government's healthcare homes was conceptually a reasonable policy, emphasising integration and coordination, but it simply wasn't backed by financial investment, and as a result, I warned that it wouldn't work. So did GPs and other stakeholders across the country. And sure enough, it's been a spectacular failure, with only 1,600 patients signing up to the trial, not even close to the 65,000 target. This was the Prime Minister's signature healthcare policy at the 2016 election. He told us it was going to revolutionise primary care, but he didn't back it with investment. So now the government is quietly backing away from the whole thing. In future, we need to offer the right incentives to providers to innovate, not just expect them to do much more with less. Investment is critically important in hospitals too. Money doesn't solve all of the problems. Clever innovation and efficiency are important. But as the AMA notes, under our current funding formula, our public hospitals will be doomed to failure. Investment in hospitals, in public hospitals, does matter as well. On prevention, on primary care and on hospitals, that's something that the government hasn't seemed to get right. We've announced already a $2.8 billion Better Hospitals Fund to pay for more activity in our public hospitals, but also to focus again on what's happening in our emergency department presentations, what's happening in elective surgery and outpatient waiting times, looking at how you actually use that fund to drive innovation. Activity-based funding made our public hospitals more efficient, and it's continuing to do so. That's a good thing because it allows for more services to be provided within the same budgets. But now what we need to do is work with states and territories to make our hospitals more effective. We don't pay hospitals for what they don't do. There's no financial incentives to prevent avoidable admissions and limited incentives to prevent avoidable readmissions. We need to create them. That's one of my key priorities in this space. Another is restoring the quality and safety agenda. The government is focused on penalising poor safety, but we also need to think about how we reward quality care. So how do we do all of this? One of the things that we talked about at the last election campaign was the need to establish a permanent Australian Health Reform Commission. I see it more in the innovation space, but that's the nature of it. The Commission would have had a broad mandate to continuously monitor and improve our healthcare system. It would focus on many of the innovations I've been talking about, developing, trialling and evaluating new models that seek to improve quality and safety, and where possible to bring down costs. New models of primary care would also have been a key focus. The Commission would have also needed to look at the way to ensure the future sustainability of the pharmaceutical benefits scheme, because we know that over the next decade, many of the new medicines expected to become available will be more specialised and more targeted, increasing pressure on government resources. We must nevertheless ensure that all Australians do get access to affordable and timely drugs that they need. I envisaged that the Commission would have become a key advisory body, but it would also have had a strong implementation agenda. It would also be a body explicitly charged with reducing inequality and improving universality of our health system. There have always been challenges in Medicare's universality, such as the difficulty of accessing services for Aboriginal and Torres Strait Islander Australians in those in regional, remote and rural Australia. People with physical disabilities or mental health issues in rural and remote Australia also face significant barriers. But in recent years, thanks in part to the government's Medicare freeze, out-of-pocket costs have also become a significant barrier to access. So we need to find ways of tackling those. These are particular issues with specialists, given that bulk billing rates remain mired at about 30%, and largely those bulk billing rates are through outpatient clinics at public hospitals. A Healthcare Reform Commission would have a standing remit to look at these issues. And the reason I think it's important is because it goes beyond, many of these issues go beyond health ministers, beyond election cycles and beyond governments. Again, the idea was something I was not ultimately able to implement, given that we didn't win the election in 2016. But I do want to make it clear today that it is not an idea that I've given up on, and I'll have more to say about that in the months ahead. I think this also shows Labor is committed to breaking out of the short-termism that can affect policy making in this country. We did that in government with the Health and Hospitals Reform Commission. Some sort of health reform commission would not win Labor any votes. It's not a sexy headline-grabbing policy. It would be pretty typical for our media people to sell it. But it would improve healthcare policy in this country for the longer term. I'm sorry to say that I don't see that sort of long-term vision coming from the coalition. Theirs is a much more managerial approach that seeks to, above all, to take the political heat out of the portfolio. They're not asking the big questions that we have been asking. And now I believe you've got some questions of your own, and I'll hand it over to you. Thanks for having me here this morning. Thanks. Just put that down.
Well,
thank you. Thank you. Okay. These are always a challenge in skirts to get up on.
Let's try not to fall off.
That's it. Beautiful.
So, look, thank you very much for those words. Clearly a huge amount of territory you've covered in a very short space. Before we get into the questions, I will point out to people that we are live streaming at the moment. So there's lots of other people out there watching this. We'll be getting questions from those people. And we encourage people to tweet in questions if you wish. There's hashtags on the wall there, George Talks and Healthy Australia. Please do send in your questions, and we'll open it up for some questions here as well as those that we receive online in a few moments. But maybe just to kick things off, Katherine, you talked about really some of the key challenges that we face as a community. I'd like to pick you up on the prevention piece, or maybe another way of putting that is the health promotion or health maintenance aspect, because prevention's a bit more challenging for some people to really understand in a way that makes them want to invest in it. Where do you see the key opportunities? Where's the low-hanging fruit in that space?
Sure. Look, I think that, again, we still have to go back to focus on tobacco, alcohol and obesity. I mean, they're the three big areas. In tobacco, for example, when was the last time we had a large national advertising campaign? And it's been dropped off the agenda. We haven't actually then looked at what's happening with smoking rates. One of the really interesting things that we had envisaged as part of the Medicare locals, and they're part of the architecture of health reform, was how, as part of the national tobacco strategy, do you then start targeting your interventions and partnering more closely at the local and geographic level with things like state and local governments, with things like where are the population groups within these areas where we're really struggling to actually affect change. So in tobacco, that's that area. And I think We're starting to see a bit of a fall in smoking rates for Aboriginal and Torres Strait Islander people, but again, we had masses of funding cut out of those smoking cessation problems. Alcohol is trickier. There is many things that we know, but trying to actually look at where do you implement those. And obesity is really challenging. That was part of the reason we set up the National Preventative Health Agency, was to actually start to do some of that research on where, and collate some of that research on where are some of the behavioural change programs. How do we actually look at population-wide initiatives where we can get change? So in obesity, for example, I think kids are an important focus, but they can't be the only focus. We won't get obesity rates down. So again, we think that issue around a national physical activity strategy, a national nutrition plan, trying to look at how do we get Australians moving more, thinking more in their environments about what they do in terms of movement and diet is really, really critically important, and it has to be very localised.
And you mentioned nutrition. And Bruce Neal would never forgive me if I didn't raise the question here. But there's clearly been a lot of discussion about taxes on, and let's be clear, sugar-sweetened beverages, not sugar taxes, but sugar-sweetened beverage tax. And progressive food pricing more broadly. I guess the Labor Party has not been enthusiastic in embracing sugar-sweetened beverage tax, but what are your views on the broader issues of incentives for healthy food and also for increased activity, for that matter?
Yeah, look, I think my experience in government was things like the things that you do by stealth are very, very effective. So the National Food and Health Dialogue, which I think the government sort of stalled for a while but has reinvigorated in a partnership arrangement, where, I think we took a substantial amount of salt out of the Australians' diet completely by stealth, just by getting food companies to sign up to targets. I think there's a question about whether that really that work needs to be turbocharged and actually look at, where are the targets? We did okay with salt, we've done not so well with sugar, and we didn't do very well with fat either. So I think there's some work there, which Australians don't recognise that happening, but that's how you do it. I think also, again, looking at the environments in which people are working, playing and are being educated, that those as vectors where you might actually provide better intervention. So things like at school, and I'll use an example at my own child's primary school, Sandra De Mayo came and did a really great program with the parents and the teachers, and including the lady who does outsourced canteen. And the school's being really challenged at the moment about its treat programs. Every reward that our children seem to get in our schools focuses around treat food in some way, so sort of thinking differently about all of those. So I think they're the sorts of things. And I think, unfortunately, fortunately, the issue around a sugar tax has been an important debate to be had. It's neither side of politics is intending to implement that. We'll certainly be watching what the UK has to do with some interest. But I think it's meant that other areas that you might focus on have also dropped off the agenda a bit, and I think it's important to really talk about those as well.
Okay. I'm sure there'll be some more questions about that, but maybe then just to ask one more question before we open it up to the audience. You talked about some of the changes that are needed, certainly in primary care and in the hospital sector, and I guess one of the principles that's relevant to both is perhaps the need for more structural change than there's been, both in terms of the funding models, and healthcare homes, one example of that, but also in the way specialist services and hospital care is provided. How brave, I guess, you talked about being prepared to take on challenges that aren't necessarily politically expedient, but some of the changes that need to be made could be quite challenging.
Yeah.
How do you see those moving forward?
Well, I think the first problem is, we've talked about integration in primary care for a long period of time, and I was involved with the evaluation of the coordinated care, the Aboriginal and Torres Strait Islander coordinated care trials. We've had coordinated veterans care, we've had bundled payments in diabetes, we've had a whole raft of trials done. The first problem we've got is there isn't a consensus in primary care about, what does primary care look like in 10, 20 years' time. We all talk about integration, but what does that mean? And so I will have, and I'm sure the Health Minister has the same, every craft group in the nation at some point in time will come to me and say, if only there was an MBS item for X, this will fix all of this problem. And the problem is that's what we've been doing. We've been adding MBS items, we've been adding practice incentive payments, we've been doing a little bit, but what we haven't done is that work to say, what does primary care look like? What is it? And then getting a consensus between all of the groups involved in that, but particularly to start with the College of GPs, Rural Doctors Association, AMA, about particularly general practice. And then once you get that consensus, then working backwards to work out what the funding model is going to look like. And until we do that, we're going to be tinkering at the edges. We're going to keep doing things. Now, there may be a possibility, again, through some of the practice incentive payments to think about that, but we've got to really go to that part of it. And the problem in allied health is that Medicare was never designed for allied health. We've added bits of MBS items on, so through the enhanced chronic disease payments through MBS, there's small amounts of allied health. We've obviously added some mental health to MBS as well. But what we increasingly know is that there is going to be a need for that much more integrated primary care. And we're going to have to think about how we do that. So the first piece of work I would want to do in government is that really strong consensus building model about what do we want it to look like, what are the funding mechanisms needed, and let's work backwards from there. Because there's no point continually trialling something if you then don't have a mechanism for funding it and rolling it out across the country. And that's been the problem with what we continually do.
Just before I do go to the audience, one last question on medical research and the Medical Research Future Fund in particular, which is about a third, I think, it's got about a third of the cash in it that was originally proposed. What's the Labor Party's view on fully capitalising the Medical Research Future Fund and how it might be used going forward?
Well, we're committed in the same way that the government is to the full capitalisation of the MRFF. It is going to take, the government's trying to pretend it won't, but it is going to take longer than initially said. It's already moved out beyond that. Again, we were adamantly opposed to some of the major cuts in health spending that saw that fund initially set up, and I think we did a pretty good job in trying to actually get health dealt into how the fund's disbursements were going to be made, what the priorities of that were going to be. I think it's going to be very important going through in the future to again look at, in our view, it should have been used to look at the McKeon review and implement McKeon. And I'm pleased to say that in some of the translational work, the government has started to fund some of that, but really going back to those McKeon principles. The challenge, of course, for us in government, which you won't be aware of, is that largely a lot of it's been spent or committed in some way. I think of the $2 billion available, 1.7's already gone. So there's a bit of the government's taking a bit of a scorched earth approach to the MRFF, I suspect. So the opportunities for us in government are probably going to be a little more limited depending on what's available and not already been dispersed.
Okay, so we might open up for questions. I'm sure there'll be a number. We've got some coming through on Twitter, and again, please do send them through. So
I see it's someone's birthday from Twitter as well. I saw whose birthday? Happy birthday! It was Jackie or someone I saw. So and Amber as well. Happy birthday!
So we've got a few questions. Perhaps down here at the front to start with.
Hi, thank you so much for your observations on the current healthcare needs of Australia and where Labor would consider going. You targeted tobacco, obesity and alcohol as primary focuses for prevention, which is great. I'm just wondering, would there be a focus on psychology or mental health needs, or looking at the drivers for overconsumption of any of these products? Because it seems too often we try and provide more information about the health risks of overconsumption when we don't really address the drivers or relationships to stress or a working week creep. I think the UK had a minister for loneliness, for example, and other things that might actually lead to the need for escapism or oblivion that humans might be undertaking.
Yeah, thank you. I think that's a terrific question. I think you're right. I think there's two parts to that. One is I think that certainly in primary care, we don't focus at all enough on the physical health needs of people who have mental health, nor do we do it with people with disabilities as well. And I think there's, again, a critical piece of work in ensuring that we actually do much better in that space. But equally, you're right, like focusing on some of those broader social determinants of health and understanding and unpacking some of that rather than just providing information campaigns. And that's sort of where I think the more targeted interventions can really be, more place-based interventions can really start to look at it. And prevention's hard. Some of the things you do, you have to trial it a bit, and you might make mistakes with that as well. So I think that you're right, that we do need to look at that. I don't think it's, we did have in government a minister responsible for social inclusion. And we don't, we have Terry Butler, for example, is specifically charged with looking at LGBTIQ inequality and trying to actually tackle some of those issues as well. So thank you for your question, but yes, you're right. We do need to do that in interventions.
And Katherine, online, we've got a couple of questions from Ian Hickey and Mandy Gibbons asking about the broader healthcare, the mental health sector. Do you think there's a need and opportunity for serious reform of that and also greater investment in mental health research?
Always, yes, in both. And Ian's obviously been a huge champion of this space and meets regularly with Julie Collins, who's the Shadow Minister who covers mental health. Yes, absolutely in both. But I think the challenge in mental health is, again, when we talk about integration, what do we mean? I think everyone sort of thinks we know what we mean. Does that mean what happens in general practice settings? What happens in public hospitals? What's happening in the community-based mental health sector? What is integration in mental health? Is that what we're after, or are we actually after more money to provide more services? What are we actually talking about? And again, I just don't think there's a consensus around that. I think there's lots of people who have different ideas. And I think the headspaces have been really important in providing that broader holistic service. But again, it's that where are the fragmentation within that system and how do we actually improve it?
So, question here.
Hi, Katherine. The federal government's now committed $900,000 to establishing a new national injury strategy. All of our national injury strategies have expired, and certainly $900,000 is not going to go that far over the next 3 years for the new one. And we haven't seen any. I guess it'd be interesting to hear what your commitment would be to injury. It's the leading cause of death and disability in children, young people of working age. We've had a sort of real decline in injury policy positions at every level of government. There's an absolute need for action on that. What's your vision?
Well, as the former Director of Injury Prevention in the Commonwealth Department of Health, I'm very pleased to hear injuries come back on the agenda. I think it is certainly one of those areas where we can have substantial change, and a lot of them are things around engineering solutions. So preventing falls in older people in nursing homes and in our hospital settings, burns in children significantly and continue to be a very challenging area. Childhood accidents, those sorts of things. The problem, I think, with the government, there are lots of. I was involved in one of the reviews of, how many national strategies, how many national action plans do we have, and how do we actually, what's actually happening with each of those. The government spent a lot of time, basically putting a lot of money into various action plans. The problem is the implementation. It's great to have a strategy. It's great to have an action plan, or it's really the implementation. And not just having an implementation plan, but the funding towards it that's really problematic. And I don't know, in terms of injury prevention, I don't even know who's left in the department, to be honest, as to who can actually implement a large number of these things. But certainly it needs to continue to be on the agenda. And it's one of those, I think injury prevention is one of those low-hanging fruits that often you don't have to spend a huge amount of money, but you can have very significant change.
So, Katherine, another question online from Mary Kelly, who says that, to make change to primary care, we need to have a vision for what it looks like in 20 years' time. How do you see it looking? Yeah,
well, look, I think that when you go back again to, the super clinic idea, for example, and what we were trying to do with that was it was catalyst funding to try and start to get general practices to be a much broader model of care. And the ones that I've visited, pretty much most of them in the country, that is exactly what they're doing. They will proudly come and tell you that, here is the psychology service, here is the dental service, here is our exercise physiology room. But the thing that we didn't do, so we provided capital for a catalyst to bring that together, was then to say, how do we deal with this funding model? And lots of general practices are doing exactly that. There's, fantastic practice I haven't visited for a little while, but over in Western Sydney, that's looking particularly at its diabetes patients. There's another one I've visited in the west of Melbourne, that the GPs, for example, every lunchtime there's a walking group that all of their diabetes patients come in, and they start off walking around the block and then they get bigger and bigger. But the GPs see that that is part of their role within the community, is to provide this activity. So that sort of integration, the issue is around funding. And the issue really, and that's really the core issue, is what do we actually do to provide opportunities for that leverage within general practice settings, whether it's within general practice settings or whether you have virtual networks. That's the challenge. So that's how I see it, is that you do have to have GPs still at the centre of care, but providing a much more holistic service. And that may well be looking at, over the longer term, whether you have fee for service for every single episode of care, or whether there are other opportunities for different payments models. And again, I don't think one size is going to fit all in the general practice and primary care space.
Okay, lots more to explore there. We've got a question here at the front with Chris. Chris Levi.
Sorry, Chris, I have to
Thanks,
prick my neck to
Catherine.
get you there.
Thank you very much, Catherine, for your lovely talk. I just was very interested to hear you mention the effectiveness agenda and the quality agenda and the reward for quality, because I think this is a potentially really powerful lever.
Yep.
Implementation of that could be very challenging. I just wondered if I could draw you a little bit out on that, because as a Research Translation Centre director, I think this would be an incredibly welcome accountability piece.
Yep. Again, this is around a couple of things. So one of the other things we had as part of a permanent health reform commission was the notion of a centre for Medicare and health systems innovation. And one of the criticisms I've had of the government's MBS review is that it's all very well and good to look at the each item, and I think that's something that it should be just ongoing, and I think it's good to say that it's happening. But one of the criticisms I've had is that what you should be doing is using it, and using any of the savings that are potentially from that, to feed back into innovation. So trying to look at, are there opportunities for shared savings models, and how do you actually then reward, so whether it's hospitals, whether it's general practices, whether it's other parts of the health system, if they are able to demonstrate MBS and even PBS savings, how are some of those savings used to then drive innovation? It's an idea I pinched, shamelessly from, the some of the good parts of the US system, which are the affordable, under the Affordable Care Act, that real interest in innovation and that move away from fee for service. So they're the sorts of things I think are going to be really important going forward. And again, it's again that architecture of health reform, building that so that it is part of the system and outlives me, outlives the current minister, outlives governments, that is actually there embedded within the system. And that takes a while to do, but I think it's a really important part of that reform.
So another question from online, Katherine, from Anthony Brown, asking about your vision for consumer, patient and community engagement in the co-design of health services and health policies. Where do you see that?
They have to be central, but it can't be tokenistic, would be my view. You've got to understand what it is that you're doing. I think a lot of people think that they're working with consumer organisations, but not, and working with consumers within their organisations, but not necessarily listening to what they have to say. They might have them on a board, they might have them on an advisory committee. Governments can be the same, but not really understanding what is it that drives and changes. So trying to get that. Our health systems are designed around funding mechanisms and around systems. They're not designed around consumers, and it's a challenging space. But I think the more people start to understand and talk about that and talk about health outcomes in that space, the better our health system will be overall. But again, it's very challenging because our funding system is not designed around that. It's not designed around a person, a consumer or a patient. It's designed around episodes of care and particular professions and how MBS pays or fee for service pays for that.
Have you seen examples where it's worked well?
Look, not particularly. I've seen examples where again, and I go back to thinking about some of the lessons from the coordinated care trials, for example, providing, buckets of funding that then allowed different things to happen. Did that, provide a good model for consumers? Probably not. I think some did. There's some interesting work, I think, happening in different primary health networks as well around this, which I think have particularly one in Queensland that I can recall, but no one's got it perfect, I don't think, unless you've got an example you can show me.
Some ideas, perhaps. We've probably got time for one more question, maybe here on the right. Just to balance the room. Apologies for all of those who we weren't able to get to.
Thank you. Tessa Boyd-Kane from Health Justice Australia. Great to hear your comments, Katherine, around prevention, integration, coordination. But really, most of the conversation so far has been around the very traditional settings of the health system. And of course, the social determinants are really one of the key drivers of poor health outcomes and indeed of the health inequalities that we've been talking about. I think over the past 10 years, we've seen a real shift across health portfolios to recognise that, but still a real challenge in what does it look like to really embed a social determinants approach in our health policy. So I guess my question is, what do you think is the appetite within Labor and even the opportunities to start tackling some of those cross-portfolio challenges like income adequacy, housing security, social and economic inclusion, not just because of their own policy merit, but because of their impact in terms of better health?
Again, I think the part of the proof is in what we're able to do in government, and there's a very strong focus on obviously on homelessness, on housing affordability, on even things like having a transport minister who in every major infrastructure project actually wanted to build in things like prevention and promotion, so walking trails and cycling trails as part of the that work, and including in sort of some of the Better Cities work that was being done. I think that, using some of the platforms we've got much more effectively. So Auntie Anne actually mentioned the Aboriginal Medical Services and Aboriginal Community Controlled Health Organisations. If you ever want an example of integrated primary care, there they are. They've been doing it for ages and are doing a fantastic job. Some are, as you know, starting to work in the justice space. So through their own funding have got lawyers and barristers and legal students coming through the Aboriginal Medical Services, like actually using those platforms that we've got. And to some extent, when we go back to what Labor's vision was in terms of establishing Medicare locals and how we again view primary health networks, is again, it's that here you have at a geographic location a body in which you can actually start to think about those place-based initiatives. And that means that you can start to think about we're always going to have the silos of portfolios and the silos of funding, but using those localised platforms to actually as a conduit for funding to get those partnerships on the ground, I think is really where the innovation is going to happen in that space. Thank you.
And perhaps on that note, with a reminder that health goes well beyond the health system, we might need to draw this to a close. Before I thank Katherine, I'd like to thank all of you for joining us on a chilly but beautiful Sydney morning, and hope that you'll all continue to engage in what's going to be a very important conversation, one that might become very pointed over coming weeks, depending on what happens. And again, then, Katherine, just to thank you very much. We're really grateful for your time. We know how busy you are, but greatly value the opportunity to engage with you, and hope that we'll be able to keep the conversation going and work together towards a healthier Australia. Thank you very much.
Thank you. Thanks, everybody, for your questions.
Still some breakfast for those who want it.
Yes.